next we're going to have Dessa Clark, our very own psych nurse practitioner here at Methodist in Fremont. We are so fortunate to have her. Dessa is going to give us some information and talk to us about navigating the promise and pitfalls of long-acting injectables. Thank you, Dessa. Go right ahead.
I'm here to talk about long-acting injectables and kind of just, it's a lot of information, so I'm going to do the best I can to keep it timely. I do not know how to keep it so I can see the chat. So if you guys have any questions, just let me know. Otherwise, there'll be time at the end for questions. So the objectives are identifying 3 types of psychiatric long-acting injectables, or LAIs, identify 3 clinical advantages of the use of antipsychotic LAIs, identify monitoring scheduling with LAI administration, 2 benefits of utilizing LAIs in clinical practice, and 2 barriers that prevent patients from transitioning from oral to LAI. The agenda is basically just introduction, talking about benefits, pitfalls, and barriers. We're going to go over the different LAIs and the uses. I will have on there the FDA approved uses, but obviously in psychiatry we use a lot of things off-label. The specific guidelines and monitoring, and we'll go over some of the things to look for, and then conclusions and questions. So what are long-acting injectables for psychiatry, and why do we use them? So long-acting injectables are an option available to prevent having to remember to take medications daily, as many of our patients do struggle with this. There are options for biweekly, monthly, bi-monthly. There are even options for every 3 months and every 6 months if it's appropriate. Intramuscular and subcutaneous options are available. And using LAIs tend to decrease the risk of tardive dyskinesia over oral medications. Benefits include improved adherence, because patients only have to remember to present somewhere once a month or less for an injection. They're generally better tolerated because it's a more stable release that will cause less side effects because you're not having peaks and troughs. Relapse prevention, leading to fewer hospitalizations, fewer ER visits, reduce incidence of treatment discontinuation. Patients tend to be more compliant, and reduced mortality. Statistics. Individuals with schizophrenia tend to affect more than 24 million people globally, and it was the 20th leading cause of death of disability, in 2019. Estimates of discontinuations rates for oral antipsychotics range from 26 to 44%, with as many as 2/3 of the patient being at least partially non-adherent. With individuals with schizophrenia, 10% of them die by suicide, and at least 50% attempt suicide one time in their lifetime. They are also 8.5 times greater risk of dying by suicide than the general population. Pitfalls and barriers to using long-acting injectables are just generalized negative perceptions, not always against the long-acting injectable, but just the medications themselves. Limited resources. There are at times difficulty getting them covered with insurances and having to go through the hoops of going through prior authorizations or trying one medication before the other. Generally not a problem in the hospital, but run into those problems if you're not aware for patients that are inpatient when they leave, so setting them up for failure. Lack of guidelines, not necessarily lack of guidelines and information about the medication and how to use them, but more tying into the next piece with clinician education and training, because a lot of these medications are still newer. If providers aren't talking to drug reps, which many people hate doing, it's time consuming, it can be frustrating, but if you're not getting that information and learning about these new things, then you're not able to treat patients appropriately. So the different kind of psychiatric long-acting injectables, that are available are both first generation antipsychotics and second generation antipsychotics. The first generation antipsychotics, and this is very basic, I'm not going to every little neurotransmitter effects, but the main property of this is to inhibit the dopamine 2 receptors. And these two medications are Haldol and fluphenazine. I'm only going to be talking about the medications that are approved in the US. There are other ones that are approved out of state. Then second generation antipsychotics work on dopamine and serotonin, and there tend to be decreased extrapyramidal symptoms, which we'll talk about later. And they are sometimes better tolerated. And this includes Abilify or aripiprazole, paliperidone, also Invega, risperidone, which comes in an intramuscular option and a subcutaneous option, and olanzapine or Zyprexa. We'll talk about this briefly when we get into it. I will tell you it's not used often because there are a lot of restrictions that make it pretty impossible to be compliant with using this. So first we're going to talk about the first generation antipsychotics, starting with Haldol decanoate. So you start out, any of these medications need to have proven toleration of oral, no significant side effects, no allergies before starting them on a long-acting injectable, because you can stop easily an oral once you've got that long-acting is in their system from 2 weeks on, depending on the medication. So it's, you don't exceed 100 milligrams for the first dose. So if they're taking 15 a day and you give them 150 milligrams, you give them 100, and then 3 to 7 days later, you give them the additional 50. If they're on 40 milligrams a day, the same thing, you give 100 milligrams, and then every 3 to 7 days add, so that you're not exceeding the 400 max dose or the 100 at a dose. For maintenance dose, it stays the same. The max is 450 then, and the dose is given every 4 weeks. For oral overlap, I have this written kind of funny, but you give the oral, and then 1 to 2 months after the initial decanoate dose, you will start decreasing 25% every week over a month. If you don't do oral overlap, you're giving 20 times the oral dose. So if it's just 10, you're going to be giving 200, but it's the same recommendations that you don't exceed 100. So it's going to be a little more difficult to get this started. Maintenance dose, you keep them on that 20 times for 2 to 3 months, depending on how they're doing, and then decrease by 25% a month to get back down to the 10 to 15 times daily oral dose. Haldol guidelines is FDA approved for schizophrenia. You give it gluteal, intramuscular. It's highly protein bound and extensively liver metabolized, so you use in caution or really avoid with patients with cirrhosis or liver failure. You need to consider a second generation antipsychotic if that's the case. Half-life is 21 days. The time to peak is 6 days. So that's when it's going to get the peak effect. Fluphenazine is the next, Prolixin's the other name for it. The next first generation, the initial dose is 6.25 to 25 milligrams. So for each 10 milligrams a day, you give 12.5. So obviously if they're on 5 milligrams a day, you give the 6.25. The maintenance starts 2 to 4 weeks after initial dose. You adjust it by 6.25 to 12.5 every 2 to 4 weeks. And then the dose range can go up to 100 milligrams every 2 to 4 weeks. The max dose they can receive is 100 milligrams every 2 weeks. Oral overlap, again, you start them, keep them on the oral when they get the first dose. After the first injection, you increase it by half and then stop after the second injection. With patients, this can be one of the biggest challenges, and that's why they're starting to come up with other options, such as the Haldol starting at the 20% to start with, because if patients are getting the injections, a lot of times they're have more difficulty remembering taking an oral medication, even if it's for a short period of time. Fluphenazine guidelines is approved for, this is an older medication, so it basically just says psychiatric disorder or psychotic disorder, I apologize. But the important thing to remember on this one, it is not effective and is not used to manage behavioral complications in individuals with intellectual disabilities. So it should not be used for that population. It's given gluteal intramuscular. It's hepatic metabolism via the CYP2D6 and is completely contraindicated in hepatic impairment. Again, consider using a second generation antipsychotic. The half-life of this medication is 14 days. Time to peak is 8 to 10 hours. Moving on to the second generation antipsychotics. Does anybody have any questions before I move on? Okay, I'm just going to keep going. We'll ask questions at the end. So moving on to the second, there are two different, technically three, but there are two different formulations of aripiprazole. You've got the Maintena formulation, which I'm going to talk about here, which is Maintena and Asimtufii, and then you have the Aristada formulation. So Maintena is given monthly. If you are doing an over-oral lap, it doesn't matter what dose they're on. You start with 400 milligrams intramuscularly times 1. Give it every 26 to 30 days. I generally do all of the monthly medications every 28 days, so it just stays consistent. If they are a poor CYP2D6 metabolizer, you start on the lower doses, which is 300. The nice thing about Maintena is the doses are 300 and 400, and that's it. You overlap for 14 days. If you're concerned that patients are not going to be compliant with the oral overlap, then you just give 2 injections. You give 2 of the 400 milligrams in 2 separate sites, or the 300 if they are a poor metabolizer, and give 1 dose of 20 milligrams the same day. Then they don't need any overlap. Asimtufii is the bi-monthly. The nice thing about Asimtufii, once you've established that they have tolerated the oral, you do not have to start with the Maintena. You can go straight to the bi-monthly Asimtufii. So you give 960 again. These are just basically 2 different doses, times 1 every 56 to 60 days. This again is a CYP2D6 metabolizer. So if somebody metabolizes that poorly, you use the lower dose of the 720. Again, you overlap for 14 days. If you do that double injection, you use the 960 of the Asimtufii and then the 400 of the Maintena, again using the lower doses if indicated, and then a single 20 milligram dose that day. Guidelines for the Maintena and Asimtufii, it's FDA approved for bipolar disorder. I have seen it used for schizophrenia off-label. The Maintena, because it's lower doses, can be given, or lower volume, sorry, deltoid or gluteal, but the Asimtufii needs to be gluteal. It's hepatically metabolized through the CYP2D6 receptors. The half-life of Maintena is 30 to 37 days. It's dose dependent. The Asimtufii is newer and it's not known yet. Time to peak is 4 to 7 days for the Maintena, and the Asimtufii is maintained from day 1 to 49. Next is the Aristada. Aristada is very similar to the Maintena, but you will see a little more peaks and troughs until it gets stabilized. And we'll kind of talk about why it's important on any of these medications to wait before you make any dose changes. So the initial daily dose equivalent is totally equivalent to what dose the patient is on. In contrast, the Maintena, it's either 300 or 400. Generally start with 400. So if they're on 10 milligrams, you give 441. 15, you'll see that there's 3 different dosing options, but that's because there's options between monthly, every 6 weeks, and every 2 months. And then greater than 20 milligrams or equal to 20 milligrams is 882 milligrams monthly. The max dose is 1,060. I don't know why that says 64 and 62. I apologize for that, but I believe it's 1,064 milligrams, and that's every 2 months. With Aristada, you have to overlap for 21 days, but this also has a dual injection option. You will give the initial dose of the Aristata, and then they have what's called Initio, which is 675 milligrams. That's the only dose. That can be given anywhere within 10 days of the initial Aristata dose. And then on the same day that you give the Initio, you give 30 milligrams of oral aripiprazole. The guidelines, this is FDA approved for schizophrenia. The Aristata can be given in deltoid or gluteal, Initio in the gluteal. And this is also, most of these are hepatically metabolized for the CYP2D6, but there are no adjustments needed. And then the half-life is 53 to 57 days. The time to peak is unknown. Moving on to the next category of medication, which is paliperidone or Invega. This medication breaks down into risperidone. You have 3 dosing options: Sustenna, which is a monthly, then Trenza, which is tri-monthly, but it cannot be started until the person has gotten and tolerated 4 doses of the Sustenna, and then Hafyera, which is every 6 months. And I can tell you that is difficult to get covered and only is for people on the higher doses of Invega. And the initial dose, no matter what dose they are taking, is going to be 234 milligrams intramuscular, and then generally on day 8, but it can be given anywhere from day 4 to day 12, 156 milligrams. For a lot of our inpatients, we give it on day 4 if we are waiting for them to discharge to ensure that they get that second dose on time. The maintenance dosing then is equivalent to what their dose is. So I can tell you the 3 milligram, 39 to 78, I've never gotten that covered, have hardly ever used it. 6 milligrams, the 117, I've been able to get that covered, but it's generally a little more challenging. The 9 to 12, the 156 and 234 are generally not difficult to get covered. However, I have not found a coupon or any kind of program, and if people do not have insurance, they're not going to get it covered. And most of the insurance require trialing the Abilify first, so that's something to be aware of before just jumping into this medication. Trenza is tri-monthly. Again, I'm not going to read all of these, but it's dose specific, and you've got to start on the Sustenna first. Same thing with the Hafyera, and it's only the 9 milligram and 12 milligram doses that are covered for that. Guidelines for all of these: it's hepatically metabolized through the CYP2D6 and CYP3A2, but it is excreted primarily through the kidneys. So if there's altered kidney function, elimination of haloperidone is decreased with decreasing estimated creatinine clearance. So it's not recommended in patients that kidney function are going up and down and are not stable. If the creatinine clearance is greater than or equal to 80, there's no adjustment needed. If it's 50 to 79, the initial is decreased and the max is decreased. And if their creatinine clearance is less than 50, it's not recommended to use this medication. It's FDA approved for schizophrenia and schizoaffective and greater than or equal to 18 years old. I will tell you this is significant because I have had a lot of difficulties with patients on even oral medications lately. If the indication is not specific for schizoaffective, sometimes you have to change it to schizophrenia to get it covered. Sustenna and Trenza can both be given deltoid or gluteal. Hafyera, because of the amount, is just gluteal. Half-lives anywhere from 25 to 159 days depending on which formulation, and then time to peak again 13 to 32 days depending on the formulation. So moving on to risperidone, which again is what risperidone breaks into paliperidone. I said that wrong, I apologize. Risperidone is initially 25 milligrams are the dose equivalent. Again, this is less than or equal to 3 milligrams a day is going to be 25 milligrams biweekly. Greater than 3, less than 5, 37.5 biweekly, and greater than 5 is 50 milligrams biweekly, and that is the max dose. Oral overlap, there are two different formulations. One is Consta, one is Rekindo. They both work on microsphere formulation, which we'll talk about in a minute. The Consta needs 3 weeks overlap, and the Rekindo only needs 1 week oral overlap. Microspheres are tiny spherical particles, very small in diameter, made from biodegradable polymers like PLGA, and they are not used to encapsulate drugs, and they are used, to encapsulate drugs and control their release over time. So microspheres, how it works, again, the encapsulation that are formed into microspheres, you inject it, and then there's a very controlled release. So the polymer slowly degrades via hydrolysis, keeping a more stable dose, so there's not as much of a time to peak or half-life. Degradation allows gradual release into the bloodstream over 2+ weeks. Some aim for zero order kinetics, which means constant release over time, and constant release avoids the peaks and troughs. Consta and Rekindo are FDA approved for bipolar mania and schizophrenia. Again, they're hepatically metabolized through the CYP2D6 receptors excreted by kidneys, so it's adjusted again per the creatinine clearance. Consta is deltoid and gluteal, where Rekindo is just gluteal. The half-life of Consta is 3 to 6 days through the microspheres, and the Rekindo is just Rekindo is strictly the erosion and absorption through the microspheres. And then the time to peak for the Rekindo is 14 days for the risperidone, and then 17 days for the active metabolite of the risperidone. Then there are the newer ones, the Perseris and Uzedy. These are both sub-Q injections. So the Perseris, you start the day after the last oral dose. 3 milligrams a day is 90 milligrams monthly, or 4 is 120 monthly, which is the max dose. So patients on doses less than 3 or more than 4 a day are not candidates at this time. There's no oral overlap. The Uzedy, again, start with the day after the last oral dose. 2 milligrams is either 50 milligrams a month or 100 milligrams bi-monthly. 3 milligrams is 75 or 150, and then 4, 100 or 200. It just goes up consecutively. And again, there's no oral overlap. The guidelines are FDA approved for schizophrenia. Again, they're hepatically metabolized by the CYP2D6, excreted by kidney, adjust per the creatinine clearance. Sub-Q in the back of the upper arm or abdomen. The half-life, time to peak. Let's move on. So olanzapine, I'm going to go over this quickly because it's not practically used. So I've got the initial, there's not oral overlap, and then the maintenance. Here's the big thing with the what? So it's FDA approved for schizophrenia. It's hepatically metabolized. It's gluteal IM. The problem is you have to go through the risk evaluation and mitigation strategies. So high risk of post-injection delirium sedation syndrome, which can include aggressiveness, agitation, cardiac arrhythmias, confusion, dysarthria, reduced level of consciousness, must be monitored, this is the key, for symptoms of at least 3 hours after injection. So maybe that's practical in the hospital, but it's not going to be practical in an outpatient setting. So, and you have to apply and go through the REMS program. So this is out there, but not a practical medication. Monitoring for any of these, every visit you need to check for adherence, mental status, ask about prolactin symptoms. That's more induced on the Invega and the risperidone, but it's still something to ask about because it can happen. Every visit for the first 6 months, and then quarterly, you need to make sure you're checking weight, height, and BMI. 4 months and annually, the hemoglobin A1C and lipid panel. Always keep an eye out for EPS and TD, which we'll talk about in a minute. Definitely be checking 4 weeks after initiation, after any change in dose, and informally with every visit. At least every month, every 6 months, or quarterly, be using a formalized scale like the AIMS Abnormal Involuntary Movement Scale, which we'll be talking about here momentarily. So when talking about EPS, people used to just automatically treat for EPS when starting on medications, antipsychotics, particularly the first generation. This is not happening as much anymore. So you're looking for dystonia, um, contractions, Parkinsonian type movements where they're slowed movements, tremors, stiff or rigid, and then akathisia. Akathisia is just the inability to sit. You feel like you need to move, can't sit still, just really restless. Neuromalignant syndrome, it's not super common. I have not seen it, but it's just something to be aware of, which includes altered mental status, rigidity, automatic dysfunction, and hyperthermia. This is a medical emergency, so it's something to be aware of. And then tardive dyskinesia is the biggest thing that we want to look for. More common in the oral, but it can happen in the IM injections. So you're looking at the eyes for, and these are all dyskinetic or involuntary movement. So you're looking at the eyes, lips, tongue, neck, torso, hands, arms, and leg. There are treatments for this that have been effective, but you can't treat it if you don't notice it. This is a big reason people will stop taking their antipsychotic medications. This is the Ames scale that I try to use every time I see a patient that's on an antipsychotic. I'm not always perfect about it. I definitely use it on people that are making changes, people that have been on medications for a long time, haven't ever really had any symptoms. I may check every couple of appointments, but this breaks it down into how you assess for it. And then the pearls. Long-acting injectables should be allowed 5.5 half-lives to reach a steady state before changing the doses or medications. So that means you're wanting for the monthly medications generally to give at least 3 doses before making any changes. They don't undergo the first pass effect in the liver, so it enhances the bioavailability in their system. They're utilized with patients with poor adherence, but they're not the only appropriate candidates. There's been a lot of research stating that these should be trialed sooner to help prevent relapses. Follow manufacturer recommendations for stable blood levels. I can tell you, Lexa, it used to be Lexicomp, I think it's Lexadrug now. I use this every time because they're always changing. Mentena didn't used to have a 1 dose or 2 injection formulation where you don't have to overlap, and now they do. So I'm always checking to make sure there haven't been any changes on that because it is the most up-to-date information. Utilize clear documentation through care transitions to prevent lapse in treatment. So that's when they're going from the hospital to providers. I'm always trying to say when their next dose is due, when they got their first dose in the hospital, when we're discharging, so that goes through to their next provider, because that is where people tend to fall out of compliance as well. If that stuff isn't, if the appointments aren't set and the communication isn't clear and transition of care. Final tips and takeaway is long-acting injectables decrease burden and increase adherence. Decrease EPS symptoms with long-acting injectables. There's several options available. Be aware of overlap guidelines for oral medications. Again, Lexadrug or Lexicomp is a great resource for tips or guidelines, and always monitor for EPS, tardive dyskinesia, and neuromalignant syndrome. My references, does anybody have any questions? That was a lot of information in a short period of time. And was this useful?
I tell you this, I really appreciate your clinical expertise, especially with this vulnerable population that would need all of those medications. I thought it was very, very helpful.
Well, and I learned a lot because I really know the Abilify and the Invega. The rest I didn't know so well. So it helps.
Very good. I'll just double check the chat here. I'm not seeing questions, but I see lots of thank yous. This is interesting and helpful and useful. So awesome.
Thank you.
Thank you.
So that was really helpful. I'm excited also for the next presenter, Dr. Leslie Crawford. She is one of our physicians at the Methodist 84th Street Hospital in their emergency department. So to kind of carry the theme for the day, obviously dealing with those high needs situations, she is going to be talking about ketamine, rapid and lasting relief for suicidality, depression, and PTSD, which is, wow, that's a lot. So glad that you are here.
So yes, I am Leslie Crawford. Thank you so much for having me. So I'm going to go over ketamine, the rapid and lasting relief for suicidality. And I do want to go through some of this quickly so that I have some time for questions at the end. And so what I want to go over today is that you're aware of the recent evidence and literature over this new application of ketamine, and knowing the limitations of utilizing ketamine in the behavioral and mental health setting. Also know the protocols for the IV use of it primarily, and then general expectations of care that you can communicate with your patients about how IV ketamine can be used in mental health. So the reason that I'm talking about this is because Happy Veterans Day, I am one of them. And that's me both in the Navy, and then I used ketamine when I was in Afghanistan in charge of the shock trauma platoon. But then also here in town, I had a ketamine clinic that I was interviewed about that I no longer have any affiliation with. Which was a wonderful experience. So ketamine, why are we talking about it, is that ketamine given intravenously may be one of the most important breakthroughs in antidepressant treatment in decades. And this is according to Thomas Insel, former director of the National Institute of Mental Health. So a very big endorsement for ketamine. So ketamine historically has been around for many decades, first known as Ketalar, FDA approved in 1970 as a dissociative anesthetic. And that's how we've been using it for a long time. They found it incidentally, interestingly, similar to PCP, but they found that it had that medical application due to less emergence delirium. And they used it in the Vietnam War, which is why I ultimately found that it's a wonderful trauma battlefield medication. However, people look at ketamine and they ask me the question of like, oh, well, isn't it used in horses, et cetera? Yes, that is true because it has a wonderful safety profile. So you can sedate animals or large, tigers without having the concerning effects of, respiratory depression or change in vitals where you create an emergency in trying to help somebody. So some key side effects and limitations that, for example, here in the emergency room or even in the clinical setting that we need to be aware of are that it can cause some nausea. And so anyone with these issues, with blood pressure issues, respiratory issues, we need to be monitoring this whenever we screen someone for ketamine for mental health. So I just want to get these over kind of out of the way pretty quickly. So these are some side effects that can happen over time with repeated dosing where you have an overactive bladder and some liver issues. So other limitations, basically what I was just saying, ketamine in the mental health setting is different than most pills because you have to do, when you're giving it, a lot of medical monitoring. Some people for mental health, when they receive ketamine, it can sound very like a curative, very fantastic outcomes. But I want to lay out from the start that there is a possibility of people being non-responders. Also, some people can go through a short course of treatment, have wonderful benefits, and yet just so people are aware that some people need boosters. And then oftentimes this is off-label and insurance will not cover. So an out-of-pocket expense can be a limitation for some people. So here's going into some of the pharmacology. It is an NMDA receptor antagonist. It is a mix of the R and the S enantiomer, which I'll get into why that's important when we talk about Spravato, which you may have heard of. IV form, half-life of 10 to 15 minutes. Contraindications, kind of relating to what I was mentioning before with the side effects, blood pressure, heart. So you would not want to refer anyone with mental health issues who is currently pregnant, and active alcohol addiction is really not ideal. And then also anyone with schizophrenia or psychosis, because you can have this associative effect and exacerbate any schizophrenia. Other people who you would want to be aware of if they are on these medications, we watch these before we give ketamine. And however, if someone has depression or suicidality who is on Lamictal, we can watch that. We simply increase the dose of the ketamine. So ketamine is known as a rapid-acting antidepressant. They found this out due to a lot of the research that I'll go into in a moment, where it works within hours to change mental health. And that, contrasts to many other medications out there that when ketamine came on the field, we found it so rapid, suddenly everything else became slow acting. As you know, sometimes you tell your patients, start taking this medication, give it a couple of weeks, sometimes months to have full effect. Ketamine is very different. So it really changes the game when we talk about behavioral health and mental health. So a lot of the literature is coming out of, these are a lot of the researchers, Yale, Stanford, big names, the Centers for PTSD. And this guy here, John Crystal, I had the benefit of getting to meet in person and was just wowed by his neuroscience. So I'll go through some of that here. And it goes into how does ketamine work for depression? Because as I mentioned, it's an NMDA receptor antagonist as opposed to serotonin or monoamines. So what he found is that there's kind of this new idea about depression that it maybe has more to do with the strength of connections in the higher brain, which is exactly where ketamine works. So that's why they got interested in this. And so some emerging theories are that it's more of a glutamate synaptic dysfunction as opposed to a depletion of some of the serotonin, norepinephrine. And what this bottom line gets down to is that it's the connections in the brain that contribute to depression are just not as efficacious. They're not as metabolically active, and you have reduced neuroplasticity. So this is where, for example, with PTSD, they find that certain areas just aren't metabolically active, and ketamine can correct some of this. So what we have here is a mouse neuron, and on the left is how it should look with the connections from one neuron to another. Those are called dendritic spindles. However, under chronic stress, what we see, this is just a normal change under stress, is that those connections drop. So that kind of points towards you have decreased connections in the brain, for lack of a better word, less connectivity. It's kind of like the messages aren't getting through. And then this is in those areas that regulate mood and depression, mood and regulation. So you have those network issues in the cortex that you have lack of communication in the brain. So you have compromised neuroplasticity, not able to adapt. And then there's not really remodeling, like say someone gets out of their acute stress reaction, there's not remodeling back to an undepressed or normalized state. So bottom line is that all this neuroscience will transfer into bigger effects behaviorally. So normally what ketamine receptor with N-methyl D-aspartate, what it actually does is it's involved in, long story short, neuroplasticity. And this is just a very dense slide about why is ketamine different. So it works on the cortex and subcortical areas by an entirely new mechanism. And what I'm pointing out here on the right, I'll have it on the slide, is that the control, you have that increased dendritic spindleization. So we're correcting those lack of connections over time due to stress. And this slide, this picture on the right with the blue, that's only one dose of ketamine 24 hours later in mice, where we see a new growth in connections, not new neurons, but new neuronal connections. So that's where it helps and works entirely differently than everything else. It doesn't just bathe the brain in new chemicals. It actually helps growth, kind of like fertilizer. Let's see my slides. Oh, there we go. Here's an analogy. It's as if your a depressed brain is kind of like has all these detours around it. So just like the highways are shut down, or if the brain connections are only A to B and there's no way to think outside of these areas. So that's why I tell people you can't think your way out of depression, because these areas are literally kind of shutting down. So what ketamine does is it kind of like puts a fresh coat of snow on the neurons so that you can create new pathways. And it decreases those blockages and increases connectivity and efficiency. So how does this look at the person level? Well, this is when we look at the whole brain fMRI. This is after one dose of ketamine in a depressed brain. So pre-ketamine, you have areas of abnormality compared to normal. And then 24 hours post one dose, that brain normalizes in fMRI studies. So kind of getting into that, which I will skip through. if you like the neuroscience. So here again is like you can't think your way out of depression. It is a actual physiologic state that we can see objectively here, that ketamine can actually come in and correct very quickly. As again, it's a rapid acting antidepressant because it's increasing that connection and synaptic density and efficiency. So ketamine does have that dissociative effect. However, we don't think that that actually is what does the reduction in depression symptoms, but it's more an indicator that we've gotten the dose right into the brain so that we can see those dendritic spindializations happening. And then people, however, will have very therapeutic involvement with these dissociative effects. And so people will describe a peak experience with for example, with other medications that are in current research stages, such as psilocybin. And I personally have seen patients in my clinic who had moments of clarity, or they're suddenly making new brain connections while under the effects of the medication, where they're able to see a way outside of their medication. And what we found is there's a questionnaire called the Mystical Experience Questionnaire, that it's as if the more mystical experience you have, the better effect the ketamine has. And so, for example, people will describe in number 8, experience of insight, that all is one. 13, sense of being at a spiritual height. So this can be a very spiritual experience for patients as well. So definitely be sure that you know this about when someone goes through this. However, here's some of the data that really goes into it. So I don't like saying that this is a randomized because they compared saline to ketamine, which ketamine has a effect. People will experience that dissociative effect. However, if you look down at the bottom with the outcomes, when people were given ketamine at 0.5 milligrams per kilogram, 2 40-minute infusions at 24-hour intervals. Within day 3, on the right there, you can see 63% had remission of suicidal ideas, and as compared to the control group, which was 31%. And then this was again only on 2 infusions. There was still a statistically significant change there of nearly 70% had a reduction in suicidal thoughts, as opposed to 56% in the control group. And this goes down into the pediatric population as well. This was just a one-time infusion. This was done at Yale, I believe, with Dr. Dwyer. Single dose, 2 weeks post-infusion in adolescents aged 13 to 17 showed dramatic improvement. And of course, this is highly encouraging because, as we know, adolescents suffer deeply with suicidal thoughts. And we want to, this is a wonderful treatment for that as well. And I personally have also seen improvement in this age group. As I mentioned, PTSD, this was a little bit tougher to look at. So what they did with the VA and Yale is they were looking again at that same protocol of 0.5 milligrams per kilogram over 40 minutes. They also did the psychotherapy, and they found that they had improvement in, they also did kind of a ketamine-assisted psychotherapy with recall of their PTSD trauma, and they were able to reconsolidate that with the help of a therapist, and they did have some improvement in PTSD symptoms after that. So with ketamine, there's a couple different medication delivery options between oral, nasal, intramuscular, and IV. These all have different costs. Insurance will cover some, and some of these need more supervision than others. Spravato is the S enantiomer of that racemic mix between the R and the S. Spravato is covered by insurance. However, it is only the S enantiomer of it and delivered nasally. This is the protocol for that, should you send someone for that. People will experience benefit. However, the issue there is that it's less bioavailable than the IV form, and also it's limited in how much you can give. So if what I'm kind of getting through here is that based on the weight of the person, they may not get nearly as much. You have to weigh about 150 pounds or less to get the same dose that is the standard IV treatment. And sorry, going back to that, there is a tolerance developed often with ketamine. Oh, sorry, was there a question? Oh, okay. So the good thing about IV is that we can adjust this and increase as tolerated with the IV form, which is what I saw very wonderful improvements with, where you have both the and the S enantiomer, which was the original FDA approved for the dissociative effect. And you can also basically, if someone has a negative experience, there is a stop button right there. And that was one thing that I did to dispel a lot of anxiety about what's going to happen on this medication. There is a stop button. The intramuscular option, however, is highly favored due to that it can be, it just doesn't require quite as much monitoring. And this is the protocol for that, where it's slightly less so that people can receive the ketamine and then go through issues with a therapist at the same time. And the therapists that I have spoken to absolutely love this and said it is really changing the game. So protocols and expectations being one of the objectives is that I love a team-based approach. There is the person who talks to the patient beforehand, screens them, has gone over medication management, but IV ketamine actually giving it with someone who is trained in airway management, blood pressure management. There's that person in the team there, but then you also have your therapist and behavioral health support who can help with the integration following. The key things about expectations of IV ketamine is that the set and setting is very important so the patient has a sense of safety. They can relax into this dissociative experience. Typically, IV ketamine is about 4 to 6 sessions. Each session is about 2 hours in the clinic, and that's over 2 to 3 weeks. And because it is a sedative, no driving or operating heavy machinery, so they need to have a ride. Some patients have such profound experiences that they'll want to, go back to college or quit college or start school. And so we always recommend that from before starting any course of treatment to delay that until there's further integration and discussion with therapists. So we want to integrate the whole person movement with this. We're sitting here in the Western medicine world, and I am part of that world, but this is a very different medication that I think requires a whole new approach with a whole person in mind, and not just see it as like I'm treating one problem in one way. It really requires this is one part of the toolbox, and the whole toolbox needs to be applied with multiple people. So that involves physicians, psychologists, therapists, coaches, sometimes social workers. And then, of course, I highly recommend involving their family and friends to be part of the support. So preparing your patients for any kind of ketamine treatment is to go over, yes, this is for suicidal thoughts, depression, anxiety, pain as well. But what is the intention as you go in? It's beyond that. So having knowledge of what the experience is going to be like and preparing them for that. And then focusing on one thing to carry them through each session and what the patient goals are for their own management. So go over the patient goals, what the therapist recommends. Okay, so what would patients describe that it's like? I had patients initially ask, can I watch TV? Should I bring a book? And I recommend no. What you'll be paying attention to is your own mind. It's kind of like meditation on steroids. These are direct quotes from patients that I had. And everyone is really different. And a lot of this goes into setting and medication. The music that goes along with it. This is another one where ketamine is like you are aware and you get to see your own mind. So it's almost like two different things. And this is an F-150 engine where it's as if everything's going all at once. What we get to do with ketamine is stop, slow it down, pull it apart, and investigate like piece by piece and how things fit together. Whether this this trauma from childhood and their boss currently and their mother and how that all is actually fitting together. But then also they can kind of go in and like kind of fix the grease of whatever is gunking up the situation and better understand how the smaller parts relate to the whole. It's also kind of like scuba diving into your own mind, but instead of just glossing over, you have the safety to really get deep into that, crevices of the mind and really get that flashlight and investigate deeper and deeper and deeper, because it feels like you have an oxygen tank on your back and the fear can really lift so that you can go back and revisit, possibly, for example, in PTSD, that traumatic moment that people really are aversive to. But the ketamine gives you that safety to explore it in that setting. So each session definitely builds, and this was a video of a flower that kind of opens and closes, where there's a kind of an opening of the mind, and each effect builds on the last, where it opens, and then you have that kind of like 72-hour time period of that dendritic spindleization, and then we would hit him with a second dose, and then you hit him with a third dose. So every time it's like literally there's a company called Mind Bloom, where ketamine can have this dramatic opening effect of consciousness. So that work rest every time, it's like a gym session for the mind is another way that I put it towards my patients. These are, this is one thing if preparing patients, I'm a meditator, and this is my Cliff's Notes on how to advise patients to be in the here and now, be in awareness, name pleasant, unpleasant, neutral. If you want to take a picture of this slide, or I can send you something later, this is like the distillation of many years of meditation, which I think is really helpful when people go into a ketamine session. So again, set and setting, making patients feel safe and welcome is very important. Dark rooms also are very important. So I personally, as an ER doctor, like to be prepared for all the scenarios. And as I mentioned, their heart rate can go up, as will blood pressure. And we want to keep an eye on oxygen, for example, if someone has sleep apnea. So we want to make sure that we watch all of this during that IV monitoring. Music therapy with non-words is very helpful to help kind of guide patients and pull them through as they're going through the experience. Many patients really start liking the music and get very involved in it. And then afterwards, kind of debriefing with the patients, either immediately or following some more integration. So these are just some tips for any therapist listening or anyone who's directly there with patients going through it. So I advise the patients to bring a journal, and sometimes they have words at first, sometimes they don't. So this is kind of what a typical schedule looks like. And this is a PHQ-9 of a patient that I had, where say on a Monday, the patient comes in, we do an H&P and we screen them. And they may have a PHQ-9 that, is very concerning. However, we'll then do a treatment. And that's what each of these different graphs indicate is a new treatment. And this was a 60-year-old patient who had suicidal thoughts kind of intermittently for about 40 years. And as you can see, in 3 weeks, session by session, she repeatedly dropped. And ideally, a patient sees a therapist once a week during these treatments. This patient had wonderful results. She came back for a booster about a month later. And then we didn't see, oh, sorry. And then she did the, she didn't get the booster, but she took the PHQ-9 scoring. And then we didn't see her for a year, and she actually did great. And we called her just to verify. And as you can see, basically cured. And as many of my patients found that they could get off a lot of their medications. Again, this is a wonderful report, and ideally it happens for everybody, but this is what's possible. So looking at anxiety, PTSD, the same graphs tend to track with the same thing. Pain, by the way, just tends to be a different protocol. Usually it's higher and shorter. So key parts are integration to go into that neuroplasticity with the new thoughts and connections. And ketamine-assisted psychotherapy is another wonderful treatment where people talk to a therapist during the treatment, and there's different techniques to direct specific therapies in that way. So I get all kinds of questions. Can you use ketamine with DBT, EMDR, etc.? Long story short, it's like the new ketchup in the behavioral health world, and the answer is, yeah, sure, why not? So, yeah, any questions?
This is fascinating. Oh, sorry.
Oh, I was just going to say that there is a question in the chat. Has there been any research on ketamine's effectiveness for someone with severe illness anxiety? If so, where can this treatment be received?
Oh, yes. So absolutely. I had patients who had cancer, ongoing cancer treatments, and a lot of that is anecdotal because it kind of all gets lumped in with depression and anxiety. So specifically for what their cause is for that, it's not really outlined in that way, but you'll see plenty of testimonials about that. So that it's really kind of hidden in the same depression, anxiety research and literature. There's a lot of stuff on psilocybin, and that's more to do with the mystical experience. Specifically on things like cancer treatment. The pain is another one because a lot of chronic conditions and severe health conditions have a lot of pain. And so sometimes you'll see that there. which is again kind of a more pain thing. I don't know if that answers that question. So I'll see if I can see the chat. I had some issues seeing this yesterday. So I know I went through a lot of that very quickly. So
Dr. Crawford, I'm curious if there's so much with integrated care and in the hospital, you know, there's such a huge correlation between like heart disease and depression. I was just curious. Sometimes we get folks that are, I'm not a medical person, but I'll just say kind of sort of medically stable for the most part. But the depression is maybe impacting their ability for discharge planning. Is this something that could be started while they're in the hospital and then followed up, or is it best to wait?
That is a great question. I would only start it if there is a good follow-up plan, because yes, there is good outcomes from a single dose. But yes, I mean, I strongly believe ketamine in any way. Can it be? Absolutely. But that would be something that I think should be done in combination with your hospital administration to start that. And also any behavioral health, psychiatrists in your facility. I would only start it if there's a good follow-on plan. But yes, for the cardiac disease, et cetera, it's definitely possible to do. Absolutely. You know, you just need to properly monitor, medically screen everybody. But I mean, again, I hate to say it, but this is a huge miracle drug and will definitely motivate patients to, come out of their depression and start taking walks. I mean, it's amazing the lifestyle changes that you can start to integrate as they go through these sessions. It's truly wonderful to see.
Very cool.
Okay, so I see some questions now. Do most insurances cover? No, they do not. This is an off-label indication. Unfortunately, it was FDA approved for anesthesia, which is why most insurances will not approve it, unfortunately. They will approve Spravato. However, Spravato, due to the nasal, only part of the racemic, limited dosing, you just don't get as much bang for your buck out of it, but that is covered by insurance. Recommended training for practitioners. So this is a bit of a Wild West with ketamine. There is a it's ASKP3, American Association for Ketamine Practitioners, that I was involved in. So as an emergency doctor, giving ketamine is part of my wheelhouse. Same thing with the anesthesia, pain doctors. So I would say for any physicians, that's the ideal training there. But then for any ketamine psychotherapy, I would say look at the ASKP3 website and start following those practitioner people who are already doing it. Where to send patients for Spravato? Can't find a place for IV. Yeah, it's because it's off label and out of pocket. So there are a couple clinics in town. And again, I was involved with one of them and I set it up how I felt was right. And I think that, as long as you just have the expectations and talk to the clinic, or even go give them a tour, that would be wonderful. So you can always just Google that and see. Okay, if a patient is receiving ketamine, they have to be on higher acuity floors. Typically not. It really comes down to if your hospital policy, what your hospital policy says. So you can always call your charge nurse or your core nurse, and it's usually it tends to be a one-on-one. At least here it can be. So yeah.
Dr. Crawford, I can speak to that. This is Shelley Holtman for Methodist and Women.
Yes, thank you.
Yeah, ketamine, if we do it anywhere inpatient, currently it is for the ICU or the emergency department or pre-op PACU only. Currently, our policies don't cover it for step down or med-surg units.
Yeah. And I rarely give it here in the ER, just so you're aware, because of that question about follow-on treatment. I would love to tell more people about it, and I have, but it's a very small select patient group that comes through the ER that I think would qualify. Did I answer all the questions?
I think so. Well, I can't thank you enough for your time and expertise. This was really enjoyable and really helpful, so I appreciate it so much. I don't see any other questions, so I think we'll bring your section to a close.
That concludes the online education. I would like to thank all of our presenters for their experience, knowledge, and expertise. Be sure to subscribe so you're up to date with all of Nebraska Methodist College's continuing education offerings. Thank you.